a lot of patients with HIV do have a substance use disorder. But what I found in this study is that most of them don't receive training in harm reduction. Some of the providers we interviewed hadn't even heard of the term.
Whoa.
That's a real problem because one thing we know is that not talking about substance use with your provider isn't super helpful. There's more substance use stigma that remains in medical settings than HIV stigma.
Have you heard the saying, the opposite of addiction is connection? We at the Addiction Prevention Coalition know that there's truth in that adage. And so we are fighting addiction face to face, conversation by conversation, creating connection. Here at The Shield, our new podcast, no topic is off limits because there are no limits when it comes to substance use disorder. Welcome to The Shield. This is an opportunity for us to highlight all of the amazing things happening in Birmingham and to also talk about how mental health and substance use really kind of intersect with all facets of life. And I am honored to have with me today Dr. Emma Sophia Kay. She is an associate professor at UAB in the School of Nursing. Did I get that right?
Correct.
Okay, awesome. You are also, this is not your first time being in a podcast situation because you had a podcast, right?
I briefly had a podcast during COVID called Health Highlights with Dr. K.
You're laughing. Why are we laughing? I would listen to that.
I don't know why I'm laughing. Because it's just one of those things that was great for a period of time and inevitably it just kind of fell off. But it was pretty cool while I had it. Covered just health topics with a touch of COVID.
That's what we were all trying to avoid back then.
Yeah,
COVID.
exactly.
Yeah. Awesome.
Yeah.
And so you just decided to do that like on your own, or did somebody kind of nudge you?
No, it was one of the, I think we all had a COVID project, and that was mine.
That was your sourdough.
That was it. But I also had, way back, like the year after I graduated college, I did an internship at a public radio station.
Love public radio.
And I got really into public radio, and so I always kind of had that interest. And so, I went back to it during that COVID era and then had some really great interviews with folks. And then, I really should have kept it up.
I know. Well, let's bring it back.
Yeah, we should.
Let's bring it back. So you're an associate professor in the School of Nursing. Mm-hmm. You're really sort of, your lane is really the intersection, and I'm saying that again, but it's true, like kind of the cross where HIV, substance use, harm reduction, communicable disease, like all kind of mesh.
All of that,
all
lots of intersections. Yes.
So how did you get into that? Because that's pretty niche.
Yeah. So while I am in the School of Nursing, actually, my background is in social work. And as part of getting your master's in social work, you have to have several field placements or internships. Mm-hmm. And while I initially went into social work, I don't think I've ever said this to you, Nicole, I was interested in working with children.
I can kind of see that a little bit. I can kind of see it.
Yeah, I love kids, but their thing at for these field placements was, we're going to kind of do a 180 and give you something you didn't ask for.
Totally different, yeah.
Yeah. So I was hoping to work with children, and my first internship was at an HIV clinic.
That is a 180.
Yeah. I really, and, looking back, it feels weird to think about how ignorant I was about HIV prior to having that placement, but I didn't really grow up during the AIDS epidemic. That was a bit before my time, and definitely wasn't taught it in school. I went to Catholic school. And so I really had no exposure to it, but ended up being great because I had no preconceived notions. I really was able to learn about HIV and what it's like to live with HIV, with kind of like a fresh perspective, a clean slate. So I was kind of thrown into this internship and really, really loved it. I loved the people. I loved the work. I saw that there were so many challenges in this field that aren't really even due to an HIV diagnosis itself. It's due to all the stigma that surrounds it. So it's really challenging work, and it shouldn't be as challenging as it is. And unfortunately, that internship was 10 years ago. Things haven't really changed too much. We still have stigma. So anyway, a lot of stigma. And it's, it's the one thing that seems to be really intractable in the field of HIV research. It's not, the advancements in the field of HIV health have been tremendous.
Yeah. Yes.
Tremendous.
Can we just pause for a
Let's
second
pause.
and talk about that?
Yeah.
Because Elvis, my boyfriend, and I were having this conversation the other day. We were talking about basketball, and inevitably we started talking about Magic Johnson.
Oh, yeah.
And,
such a cool guy.
Right. And he is, 51 or something like that. I'm 44. So we did grow up during that time where it was like a scourge and a death sentence. And if you got HIV, it automatically turned into AIDS. And then basically you were dying. And it was very stigmatized to the LGBTQ community. Yeah. And people thought that, you could sneeze and get it. But now, like, we were talking just about, like, PrEP.
Yeah.
And how the pharmaceuticals you see on TV that are advertised, that are talking about, help a lay person understand just how modern medicine, modern science has really changed the game for people with HIV.
Absolutely.
It has changed the game.
It has changed the game. So really, so the most recent advancement, so for a while now we've had, people with HIV can take a once daily pill. It's antiretroviral therapy, and they're good to go.
And it basically increases
it lowers the viral load in their body.
Lowers the viral load.
So you want a suppressed HIV viral load.
Okay.
But over the past couple of years, we now have a new option on the market. It's injectable ART or antiretroviral therapy. So it's rather than having to take a pill every day, you can go get a shot.
Yeah.
Every 6 to 8 weeks, something like that, and that's it.
Which is kind of like I'm probably going to lose audience members listening saying this, but it's kind of like having to take the pill every day versus getting the shot or getting an IUD or something. It takes the remembering out of it.
Yeah, because it is, the field has, the gains have been tremendous, and taking a pill every day isn't the end of the world. It's also, none of us are infallible, and we forget. And to have that, anything that science can do to take the burden off someone living with a chronic condition is good. And so really now the field is all about injectables and giving people options, right? It's what kind of antiretroviral therapy method do you prefer? Some people might prefer to take a once daily pill. Some people might prefer to take an injectable. We're really now in an era of patient choice. And it should be that way.
Yeah. What is PrEP? Because I'm gonna so at one of our community advisory board meetings not that long ago, which you are a member, we had some researchers from UAB come on and ask some questions from our board about what gets in the way of people taking PrEP and what could be done to maybe promote it more or decrease barriers. Can you talk a little bit about what PrEP is?
Yeah, so PrEP stands for pre-exposure prophylaxis. And it is, like treatment for HIV, it's now evolved to have either a daily pill option or an injectable option. But it's for people who are not living with HIV.
Right.
But it's to prevent acquisition of HIV. And that's been another advancement over the past, maybe 5 to 10 years. I don't know. I could be getting that wrong. I'm trying to think when the FDA approved PrEP. anyway, it's all about prevention of HIV. The interesting thing about all of this is that, so because of the way that the health payer system is set up in the U.S. and the fact that we have had the federal Ryan White HIV/AIDS program,
Yes.
that's a tremendous program, which actually was the focus of my dissertation.
Oh, really?
It's one of my loves. It's a tremendous program, but
So this internship really did change your life.
it literally
after that,
did.
you were
I
just
was
like on a different path.
Totally.
Awesome.
Absolutely. So
you did your dissertation on the Ryan White Act.
Yeah, the
Yes.
Ryan White program and its
okay.
association with HIV health outcomes. Essentially, it's really kind of a gold standard program because it does provide primary health care, but it also provides supplementary health services. So things like nutrition assistance, transportation, just all of the things that a person who is either uninsured or underinsured would need to stay healthy.
Because it is an expensive disease.
Yeah.
I know the cost has gone down right, over the years, but if you have that diagnosis, it's costly.
It is. And, for those, again, who don't have health insurance,
Right.
it's completely cost prohibitive. And so the Ryan White program, it's really a payer of last resort, and it's allowed about half of all people with HIV receive services from the program in the U.S. The thing about it is that while all of these resources are available for people with HIV, for HIV prevention, so PrEP, we don't have this program set in place that helps offset the cost. So cost, at the end of the day, is really one of the primary barriers to PrEP.
Yeah. Last summer I was talking to a friend of mine's friend, and they were together. And he was also with some other folks from different genders. And he was sitting across from me just having the most open conversation about PrEP and how everyone in his community uses PrEP. And
That's great.
Dude, it blew my socks off.
That's great.
Because as like a public health nerd, I was like, oh my gosh. But he did say that he recognizes the advantage he has, that he can afford PrEP.
Mm-hmm.
That not everybody can, but
Right.
that he was really hoping that would be something that would change because of just how he said how it's really informed how he chooses to protect himself.
Right. So it is a tremendous resource to prevent HIV, but it does need to be a lot more affordable for everybody to be able to use it.
So when did the, I'll say, research or interest in the crossover between substance use and HIV and other communicable diseases, when did that come into play for you?
Yeah. So I really credit my friend and colleague at the University of Pittsburgh. She was really the driving force, but behind this interest. So I've already mentioned, how I didn't have a lot of exposure to HIV. Then I did, and I loved it. Similar situation with substance use and harm reduction, especially. So, right, I went to college, got my undergraduate degree, master's degree, and PhD in Alabama. And so I've not lived in a place where there were a lot of resources for people who use drugs. And really the harm reduction landscape in Alabama isn't super robust. But in Pittsburgh, it really is. And so learning about all of the amazing resources they have in Pittsburgh, and also the challenges in meeting the needs of people who use substances in a resource-limited setting like Alabama really became interesting to me. So I've always been interested in fields that are associated with stigma because those I feel like those are the areas where there's the greatest need for resources and for research
And if you have a person with
all the
HIV
things.
that is also using substances, holy cow, like the stigma, that's like a double stigma.
So much, right. And about half of people with HIV have a substance use disorder. So it's definitely a common comorbidity. I just didn't appreciate that additional layer of substance use and the stigma associated with it until collaborating with my colleague in Pittsburgh. And now it's become probably my greatest interest because it is just, I mean, there are just not a whole lot of resources for this community. And Alabama has really, unfortunately, kind of lagged behind other states. It's kind of one of the last frontiers.
Yeah.
I feel like.
So can you talk about a couple of things that are happening that like really get you excited? Because when we're on like Zoom calls or whatever, like you'll hear something or it's like something just like wakes up and then it like kind of gets you going. So what's happening right now that either you're a part of or you have students that are part of that you are geeked about?
Yeah, a couple of things. So one thing that I'm really excited about is one of the studies that I lead with my collaborator in Pittsburgh, really focused on understanding the ways that HIV providers work or provide services to people who use drugs. So again, a lot of patients with HIV do have a substance use disorder. But what I found in this study is that most of them don't receive training in harm reduction. Some of the providers we interviewed hadn't even heard of the term.
Whoa.
Yeah, so there's a real dearth of knowledge, and I'm not...
Whoa.
Yeah, so I'm not blaming the providers, but if you start to really dig into it, you see this really isn't a part of their training.
Yeah.
And that's a real problem because one thing we know is that not talking about substance use with your provider isn't super helpful. And so a lot of these providers aren't even asking. If they are, they're not creating an atmosphere where patients feel comfortable discussing it. And there's a lot. What I found is there's more substance use stigma that remains in medical settings than HIV stigma, just in my own research. It's really, substance use stigma is really prevalent. And so what we're working on is developing an intervention that really situates itself in what we call relational harm reduction. So structural harm reduction would be the resources like naloxone, test strips, syringe service programs, which may or may not be present in every area of the U.S. But relational harm reduction, you can do anywhere. It's not policy dependent.
You're just having a conversation.
You're just having a conversation. And it's that relationship between providers and patients. So what we're really focusing on is ways to basically teach providers how to have these conversations and how to make sure that substance use is something that's addressed with their patients who have HIV because, again, it is so prevalent. So I'm really excited about this whole concept of relational harm reduction because it's again something that you can do anywhere.
It's cheap.
It's cheap. I think that most providers are open to the idea. They just, again, haven't received training. And I think it could really help decrease the substance use stigma that we see. So I'm really excited about that.
Awesome.
Yeah.
Awesome. So what is the next step with that?
Yeah.
Yeah.
That's always the hard part, right? You collect a bunch of data and you see patterns and themes. So it's like, oh, what's next?
Yeah.
So what's next?
Well, and getting into medical schools to increase their training is really hard. I know Shane Herring is working on that with the addiction scholars. Like it's hard. It's not impossible. It's just hard.
It's hard. And so, the only way to design interventions I think appropriately, are to bring everyone who would be involved in the intervention to the table. So that's people who would use the intervention, so patients, also providers, harm reduction experts. It's really important to use co-design, human-centered design methods if you want it to be successful.
And I think a lot of people, especially if you're in, if you are facing two stigmatized health challenges, HIV and substance use, you're going to be way less inclined to ask questions of your doctor,
absolutely,
to advocate for yourself. But patient advocacy is in my brain, is such a huge piece of this.
Yeah.
Like, I don't think a lot of people know that they get to tell their doctors or dentists no. That they get to say, I don't want that medication, or, hey, I do want this, or can I have a few more seconds of your time? And I know that some people might be hearing this and are like, well, you can't do that. They're a doctor. They're wearing a white coat. Yes, you can.
Yeah.
But not everybody feels comfortable or confident, especially if you're embarrassed, you don't even maybe know you have it.
Right.
You are in denial, like whatever. I mean.
Yeah, you're spot on. And so we also have collected data from patients. And one thing that we've learned from them is a lot of them do have this attitude towards their provider of like, the provider is always right.
Yeah.
And it's a little bit of a dangerous situation because they don't feel like they can say no. A lot of them are just, it's like, you see the white coat, right? And we all have this, I think everybody gets a little anxious.
Totally.
But it's this whole sense of like, I'll do whatever they say.
They went to all this schooling.
Yeah.
They obviously know better than I,
right.
Like there's like a power differential.
That's the word I was trying to think of. Yeah, definite power differential. And so again, if you have that type of atmosphere and the provider is not mentioning substance use or worse, mentioning it in disparaging terms, then what does that mean for the patient and their health? So yeah, there's a lot of work to be done.
A lot of work to be done, but a lot of work happening.
A lot of work happening. I will say, I know I've said a few maybe not so positive things about our state, but at least the folks that I work with in Birmingham, UAB, Nicole at APC, there are some amazing harm reduction advocates in this area who have done already so much work and so much more things to come. So I'm really excited to see kind of what happens next in this city because there's so many people here who are passionate about creating a more accessible space for people who use drugs.
I completely agree with that. I am continuously pleasantly surprised by how many innovative, scrappy, research-based things are happening here in Birmingham. And when I first moved here, I mean, this is going to sound silly, but I knew UAB was here. I didn't really know just how much of a stronghold it is in the city, but also in the United States in terms of research and the amount of research that comes out of UAB, particularly out of CAPI, which I want to talk about in a second, around substance use is, I mean, I've never seen anything like it, and I've been in this field for almost 20 years.
Yeah.
So talk about CAPI and kind of what that is and how it's really lending itself to the advancement of the field, because it truly is. I mean, it's pretty incredible.
There's some amazing researchers at UAB. So CAPI is a center at UAB. It's Center for Addiction and Pain Prevention Interventions, I think.
Yes, you're correct.
You're
correct. I was tracking in my brain. Yes.
Okay.
You got it. Center
so
for
many
Addiction
acronyms.
and Pain Prevention Intervention.
Yes. So, and it's led by people with expertise in addiction research, harm reduction research, as well as pain research. And the director is Dr. Karen Cropsey, who's
she's awesome, dude.
She
is so cool.
She's really a research powerhouse. She's the grant writing queen. Nobody writes more grants than Karen
You
does.
get into a room with her and you're like, whoa, you are very cool.
Yeah, she's one of my favorite people. But
and she's kind of a bulldog too, which I love.
Well,
she is
same.
awesome.
So, something I work on continuously, and it doesn't come naturally to me, is being assertive. And she has this amazing assertiveness about her, but kind.
Totally.
Always kind.
Yep.
So that's who I want to be.
Yeah, she's cool. We can both aspire to be her.
Absolutely.
When we grow up. Yeah.
Absolutely.
So she leads this center, and it's called a We Work.
You Work.
You Work.
Yeah.
Ah, shoot, I was so close.
You were so close.
So close. Okay.
Please don't ask me what that stands for.
I will not. But basically, it's like a center or like a...
It's a university-wide center.
Yes.
So,
which is cool because it gets people from
all different
parts
disciplines.
Yes.
And I love that. I love collaboration. Interdisciplinary collaboration is even better. And so we have folks from nursing, medicine. We have someone from philosophy, which I think is really
very cool.
All different types of perspectives in the room. And really the goal is just to continue and promote research in this area of pain and addiction. And Nicole is a part of
I don't
CAPI
even know.
as well.
I was just going to say, I was in
Let's
the
not
room
forget
for that
that.
strategic planning session, and I was like, which one of these is not like the other? Like, you all are like
No.
very like, I don't, academia can be intimidating. We've talked a lot about that, but I don't, about things being intimidating, but you all did not make it feel intimidating because you're there cross disciplines
Right.
to really advance the field, advance the thing that, we've all dedicated our lives to.
Yeah.
Right. I mean, we're
Absolutely.
not in this because it pays well. We're not in this because it's super fun and uplifting and optimistic all the time.
Right.
Like, we are really trying to make inroads to prevent, treat, reduce substance use disorder and help folks recover.
Exactly.
And, I mean, you could feel that. There was really no intimidation.
No,
because
because
it was really cool.
Everyone's expertise is valued, and there's academic expertise isn't any more important than any other type of expertise.
But it is important because you all do the research.
Wow.
I mean,
I'm
I'm
biased towards research.
Okay, I believe in science. And, I was listening to something the other day that was talking about expertise and how everyone's an expert these days, but they're really not. Like, you can pretend to be an expert, but if you study this and this is your life's work and you have data, quantitative and qualitative data to back it up, you're the expert, even if you don't have to look down from your ivory tower and say, I'm the expert. But, like, you get to, like... have an expert opinion. I would like to think I'm an expert in prevention because this is what I've done for 20 years.
Absolutely.
So but that comes with time and dedication.
Right.
And work and research. Yes.
Yes. But you and I lead the community. So CAPI, because there's so many different types of experts and disciplines.
Totally. That's right.
There are different leadership groups within CAPI. So some are focused on advocacy, some are focused on education, some are focused on...
like recruitment of people for research, yes.
But our specific area is community engagement and outreach.
That's right.
And absolutely, you have expertise in that area. So Nicole and I get to sit and plan events and ways to engage the community more and get the word out about CAPI, get the word out about APC and the amazing things that we're doing together.
Yeah.
And that's a big part of it because you mentioned the ivory tower, and it does exist. And I think a great disservice is when you do a bunch of great work in science and it doesn't get disseminated very well.
Right.
And
that's like half of
yeah.
the work, right? Is not just doing the research, but then also making sure that it's understandable and translatable and has been disseminated into all of the appropriate places that it needs to be disseminated.
Right. And that's really important to CAPI. And that's why we have this subgroup that is focused on community outreach. Right. We have to share the knowledge, right?
Yeah. Well, and I am really privileged really grateful, I should say, that you have agreed to be on our newly formed, still in formation,
burgeoning.
Yes, I love that adjective. Yes, our junior board of APCs.
That's right.
So really excited about this. And could you talk a little bit about what that means?
Yeah.
What that is?
So this is a great group, by the way. So it's people who are passionate about all the things that we've talked about today: prevention, treatment, making life and all the things better for people who use substances. But this particular group, it's a very active group.
Totally.
So we're focused on engaging with the community, reaching, in particular, younger people who might not have a safe community to interact with. So our first event tonight at Mayo at 6 p.m., it's a fundraiser. So it's a really amazing chance for us to get together and create a place that, while it may be at a bar, there are mocktails being served, and we can socialize and be with other people without the pressure of alcohol. Because that's definitely one need that the group has identified. You know, a lot of socialization is built around alcohol. It's really the fabric of American society, but that doesn't work for everybody. And people should still be able to get out and mingle and have fun without that pressure. And so we hope that this will be the first of many events that provide that socialization in a safe space.
Yeah, and it is a very active group. It's very diverse.
Very.
So it's, there are some people who work in the nonprofit space, some people who work in tech, some people who work in academia like you, just a real diverse group of people who are all united in two goals: to help draw attention and uplift APC's mission, and to help create an NA space where you can still network and schmooze and advance your career, but you don't have to worry about what you said,
right?
Or who you hit on or whatever, like, cause you're all sober, but you still get to like network and like have a good time and trade business cards.
Exactly.
And we say it's 25 to young at heart.
Right.
So
Exactly.
some people who might be listening are like, well, I want to join, but I'm 45. Well, who cares?
Yeah. We don't age restrict at APC or in the junior board.
It's for people who want to get involved but don't want any sort of a financial commitment.
Exactly.
Maybe
that's the other piece.
they are younger in their career because they've taken a windy path, right? Yeah. And we want to leave it open. And we know that it will become, for some folks, a stepping stone to the full board. Right. I was going to say the old board.
We try not to use...
I wasn't going to say old board.
Ageist language here.
But we do hope that it will become sort of a feeder for the full board, which would be awesome. Yeah. That's a goal.
Yeah. And I think we can do it. We also, a lot of members of the junior board came out at the End Addiction Walk.
Which was so awesome.
It really was. It was just the best.
It was so cool because some of you were there for your day jobs. Some of you were there for junior board. Some of you were there just because you wanted to support.
Right.
It was really great. And I know the full board is really excited, as am I, about what's to come. And I do think that there is a thirst, pardon the pun, for an NA community. Yeah. Particularly in the prevention or in the professional space. Like if you look at other junior boards or young professional events, they're always pub crawls. Yeah. A kick the keg thing, and like cool. That's
Yeah.
great. But that
Yeah.
doesn't work for everybody, like you said.
No, it doesn't. It doesn't. So, yeah,
It's just an alternative.
It's an alternative, and it's all about. Wow, I think I can bring it back to our earlier conversation about patient-centered
Circle it
care.
back. Let's do it.
Right? It's all about giving people options.
That's right. That's right.
Yeah.
Thank you so much for being here. I had such
Thanks
a great
for having
time.
me.
Yeah, I really enjoy getting to work with you. I feel like we are in various meetings and various things throughout the week, and I'm always just like, you're just a friendly face and a voice of reason and compassion on the other end of the Zoom screen. And I just really appreciate that. So
Likewise.
thank you for being here.
Thanks, Nicole.
If you liked what you heard, and I know you did, please consider rating, reviewing, and actually subscribing. That's awesome if you do that, to The Shield.